Hi, everyone, and welcome to today's WALPN webinar. I'm Marcy Hubbs, the manager of Well Ahead Louisiana's Provider Education Network, or what we call WALPN. Thank you so much for joining us today. Before we get started, I'd like to go over some general information regarding this webinar. This webinar will be recorded and posted to www.walpn.org following the presentation. And an email including the link to this recording and all the materials presented during today's presentation will be sent to all who registered for this webinar. This email will also include a brief evaluation, so please take the time to provide us with feedback to direct future webinars. If you have any questions during the webinar, please type the message in the chat box and we'll do our best to address it. Please hold all of your content-related questions until the end of the webinar. We will have time designated at the end of the presentation for Q&A. And at that time, we'll ask you to type your questions in the chat box and the speaker will then address. So we now bring you today's webinar focused on incorporating health literacy in diabetes prevention and management programs. We are pleased to have William Juzang and Pamela Weddington from Me Productions with us today. William Juzang is the Vice President of Me Productions, and his expertise lies in producing and implementing initiatives that address issues that impact underserved populations in rural and urban settings. He is an experienced focus group moderator for qualitative and quantitative audience research projects and expertly uses this information to develop effective communications that is culturally relevant. Pamela Weddington will also be presenting today. Pamela is the Vice President of Communications for Me Productions, where she oversees the development and production of various types of communication material, including print, graphic, audiovisual, digital, and other communication materials. Her expertise lies in the analysis of qualitative research data and translating it into messaging that resonates with target audiences. Our speakers have some very insightful information to share with us today. We're so grateful to have them share key information found from their focus group studies. I now hand it over to William Juzang.
Thank you, Marcy. Thank you, everyone, for joining us today. Again, my name is William Juzang, and I'm joined by Pamela Weddington. A couple of things before we get started. Like probably most people on here, Pam and I are both working remotely, so we're not together. So I just wanted to make note of that. We're going to do our best to transition as seamlessly as possible from speaker to speaker as we can, but you know, we're not in the same location, so we can't do that as easily as always. Also, we're going to be showing a few video clips through this presentation. Just we thought it would be a good idea to not only let you hear from us, but hear directly from the Louisiana residents that we spoke to as they, discuss the topics that we're going to review today. So let me just give you a quick outline of how we're going to go about this presentation. First, what we wanted to do is just talk a little bit about cultural competency, why we were doing these focus groups, why we thought it was important to hear from the audience and understand their worldview. We'll dive a little bit into the research design, just to give you a quick understanding of how that went about. Give you a quick snapshot of the participants so you understand some of their demographics, psychographics, and then we'll get into the key findings, and finally the recommendations that we have for providers from a both programmatic and operational standpoint, as well as messaging, and also as well as some outreach strategies or promotional strategies you can do to promote your prevention programs. So first off, let me turn it over to Pam to talk about why we did these focus groups, the importance of not only understanding how your target audience perceives your service and your program, but also understanding the importance of their worldview and how they see the world and how they see the community that they live in. So let me turn it over to Pam.
Great, thank you, William, and good afternoon to everyone. First, let me step back just a little bit. The title of our presentation is around incorporating health literacy. And when we think about health literacy, personally, I don't like the phrase as much because it tends to kind of make people think of it in a binary way. People are either literate or they're illiterate. But as human beings, we know that we are very complicated people. All of us are. And so I want to talk a little bit from a more nuanced perspective that will help you in communicating with the patients and other folks in the community that you come in contact with. Now, the idea of cultural competence is really about understanding the person that you are communicating with. What are the things that are going on in their lives, in their community, how they're treated by society that may impact how they hear the messages that you're delivering to them. And then once they hear those messages, are there barriers that may prevent them from acting on those messages in the way that you would prefer? So for Me Productions, we always talk about understanding point A in order to get to point B. So in this model, point B is where you want patients and folks in the community to be at the end. In this case, we want to prevent diabetes where we can, and in cases where people have been diagnosed with diabetes, to help them manage that disease. So we know where we want the end game to be, but I think a lot of times we forget where the patients are starting from, and that's what we call point A. So it's really important to understand the receiver's worldview, and perhaps many of you are familiar with the term social determinants of health, but in Me's work, we've kind of broken it down into what we call 8 variables that impact people's decision-making and the choices they make. And you see these 8 variables here. All of these play into decisions that folks in the community will be making, and you need to be able to understand the audience in order to develop your messages and the tactics that you're going to use to be able to help them make good choices about diabetes prevention. My background is in communications, and I don't know if there's any other former communication students on the call today, but there's like 4 parts to the communications model. There's the sender of the message, there's the message itself, there are the channels through which you send that message, and then the receiver. A lot of folks, when they're developing health communications, would say that they follow that message, but where they start often is the message sender. And for Me Productions, when we're doing our work in the community, particularly around behavior change, we start with the receiver, because understanding the receiver, what their barriers are, what their past experiences are, is important. And then we work our way back from each of those. So as you see the findings and recommendations that come from this audience research we did, kind of keep that in mind, because these are the things that are going to lead to helping you be a better communicator with folks that you come in contact with. William?
Thank you, Pam. Appreciate that. So now we want to move forward with the explaining the research design quickly. We did 6 focus groups with African American adults. All the participants either lived in the Shreveport area or Lafayette area, and the focus groups were moderated by myself and the president of Me Productions, my brother Ivan Juice. The design, we were looking to really understand participants' lifestyles, thoughts on healthcare services in their community, their overall knowledge of diabetes and prediabetes, and then how Well Ahead and partners and providers like yourselves can increase awareness of these diabetes prevention programs in the community and have that be at the forefront of the discussion. So prior to each of the focus groups, we asked the participants to do a short focus group survey, because we always like to try to get a little bit of quantitative information from them. So here you'll see that the average age was 49. The participants skewed female with 85%. Now, interestingly, 100% either strongly agreed or agreed when we asked them or gave them the statement their health is very important to them. But interestingly, only 40% strongly agreed or agreed when asked if they were actually living a healthy lifestyle. In terms of income, 59% of the participants were from households with an average household income under $25,000. And when we also asked participants what they considered to be their two most concerning health issues, 41% selected prediabetes or diabetes, while obesity, cancer, heart disease, and stroke all came in tied for second at 33%. A few other things we asked general questions about health and wellness. We asked about their consumption of fruits and vegetables, as well as their physical activity habits. You'll see that 83% strongly agreed or agreed that obesity was a problem in their community. And then when it came to media usage, Facebook was the most commonly used app, with 79% having used that within the last week. Pandy, do you have anything to add?
Sorry, I forgot to unmute myself.
No,
no, I'm good there. Thank you.
Okay. So let's jump into the key findings. So the first area that we wanted to get an understanding was people's knowledge and attitudes as it came to nutrition. So the majority of participants felt that good nutrition and eating healthy were important. The only ones that really weren't overly concerned were, we had one or two participants that were under the age of 30, and they, said that just really wasn't a focus of theirs at the moment. The challenging aspect for participants, however, was actually incorporating good nutrition into their lifestyles. Issues such as a high cost, lack of time to shop and prepare healthy foods, and a lack of convenient access were all primary challenges that participants faced. And particularly when it came to food consumption, we found that women were often the behavior change agents for their families. We heard a few instances where, whether they were changing habits due to illness or wanting to lose weight, the mothers or wives were able to impact the way both their children's and their spouses ate because of their habits. Pam, you have anything to add here?
Yeah, I think, what's important here is noting the gap between what people know they should be doing and what they're actually doing. I mean, and this is not just limited to rural African Americans. I think most of us would say, yes, I could eat healthier than I do, especially when I'm stuck on lockdown and, I've got to do something to manage my anxiety. So where we might say, okay, there is a knowledge around the fact that eating certain kinds of foods will help people be healthier. I think when we're developing messages or even having conversations with people about how to put that into their daily lives, it's important to at least acknowledge and recognize the barriers that make that difficult for them. And if you have some ideas about how they can overcome or reduce those barriers, that should also be part of your conversation.
Exactly, thank you, Pam. So next, we shifted the conversation to talking about diabetes. And, I have to say that, I knew diabetes was an issue in the African American community across the country, and speaking to Well Ahead, we knew it was an issue in Louisiana, but I didn't realize, that it was to this extent. I mean, we had more than about 81% of the participants in the groups were either personally diagnosed with prediabetes or type 2 diabetes or knew someone who had been diagnosed. And often they knew multiple people. And these are just, random participants that we, selected through our screening process. But participants were able to vividly describe how their lives or the lives of others had been negatively impacted by diabetes. Some suggested that people in the African American community might actually have been, in a sense, desensitized to diabetes because it was such a common occurrence, and so many people had either been touched by it, either themselves or through people they knew. We also found that members of the African American community mostly aligned diabetes with one's intake of sugar, and they were less aware of the involvement of functioning of the organs and things of that nature. And when it came to diabetes, type 2 diabetes was not something that was commonly known. People typically just knew of diabetes, and they commonly called it sugar diabetes or used the term having the sugar. So it was very much associated with, sugar consumption and things of that nature. So from this, we think that there's an opportunity to reframe the discussion about diabetes prevention in the African American community, because participants stated that diabetes prevention messaging should focus more so on the negative impacts to your quality of life, including for those who may have to take care of you if you become ill. So it's not just the impact that it has on your life, but the impact on those who have to care for you. And we saw quite a few participants talked about, seeing people in their families go through diabetes, seeing what they had to do to take care of themselves, seeing how it impacted them, and they knew that, they didn't want to leave that, leave that for their family members or their children to have to deal with that if they had diabetes. Pam, did you want to add anything here?
Yes. So this kind of ties into some of the messaging piece. I'm sure you're familiar with the idea of meeting people where they are. And so I think you'll see this come up later in the recommendations is using the same way to refer to diabetes and the disease as people in the community do is meeting them where they are and helping them get, first of all, the broader understanding of it's not just, sugar that is causing the issue here, but understanding the scientific undergirdings of that helps. First of all, it helps create the credibility that you're talking to them in a language that they commonly use and recognize. And then from there, you can help steer the conversation to, more correct or scientifically detailed information.
Thank you. So what I'd like to do now is just play a clip from some of the focus groups so you can hear some of the participants talk about the impact of diabetes on their personal lives.
I once was diabetic. I lost a lot of weight, and I changed my eating habits to eat healthier, more fruits, vegetables, things like that. I have a daughter that's considered obese for her age, and she's pre-diabetic now.
My first cousin, they cut off both his leg.
My aunt, one time, she was diabetic. She had a cut on her foot. And she always had a rat tail comb, and she couldn't reach her foot, so she scratched her foot with that rat tail comb one day. I couldn't have been any more than maybe 4 or 5. Her foot never healed. My aunt passed maybe when I was about 16, so I know for 10 or 11 years her foot never healed. She could never wear a shoe again. My dad, he was diabetic. He was on the pills, but he worked for the railroad, and he wasn't ready to retire just yet. So when he did retire at 61 and he got on insulin, it was a bit too late. and the diabetes had taken such a toll on his body that he had a massive stroke, and he died.
My sister that passed last year, she was diabetic. And she could tell me when her sugar was too high or too low and what we needed to do to help her with it. And that's the only reason, I mean, as far as it being 1 or 2, I have no idea.
Well, I have a cousin that passed from diabetes, and I have a best friend that he struggles with it, and sometimes it's worse. So I always try to make sure that he doing what he need to be doing.
Now for me, I know one of my earliest childhood memories of my great aunt that had her leg amputated. I remember my great grandmother going and giving her shots every morning and checking her blood sugar. And then my mom is a diabetic, and my brother.
I remember my auntie giving herself a shot. My grandmother had her leg amputated. I had a cousin who had his foot amputated. I have, my mom is, and I have a couple of teenagers. Well, they're not teenagers now, but they were diagnosed as teenagers.
Okay, so next we shifted the conversation to start talking about prediabetes. And I think, one of the things that just really stood clearly out to me was, from this discussion that we had, was that there just needs to be more education in the African-American community when it comes to prediabetes. Only a third of the participants in the groups were familiar, with the condition, and those who were typically either had been diagnosed during their pregnancy or, had known somebody who had been diagnosed by prediabetes. Some had heard the term borderline diabetes, but they still weren't clear as to what exactly that meant, what the implications were. So there definitely needs to be some education around the condition of prediabetes. And what we found were there were really 2 types of misconceptions about prediabetes. The first one, and the primary one, was that there was a sense that if you were pre-diabetic, then you were really already diabetic. And so as a sense, there was nothing you could really do. It was almost like you were destined, just to have diabetes. The other was, and this was a little less common, but we also heard it, was that if you're pre-diabetic, you really don't have to worry because you're not diabetic. So, you're in a good place. So those were 2 of the kind of misconceptions that led to people not really thinking about making any lifestyle changes at that point. And then now what we did do is we gave a description of prediabetes to the participants. And once we gave that description, we asked them, okay, now that you've heard that, how do you feel about it? And once they had a better understanding of what prediabetes was, they thought that it was an extremely serious issue that needed to be, taken seriously and more education around it. Now, we found that the prediabetes risk card, which we have images there, not sure if you can see it clearly, but hopefully many of you are familiar with this. We found that this was a very valuable tool for when it came to raising awareness and just making people understand prediabetes. And this is something that we'll get to in the recommendations, but I think this is definitely a tool that can at least be used to get people thinking about prediabetes, the impact of it, and possibly, the things you have to do to change your lifestyle. Pam, do you want to add anything to this?
No, I'm good.
Okay. What I would like to do next is show you guys another video clip, and this is participants talking about their knowledge of prediabetes.
I think that there's more information out there about having diabetes than there is about pre-diabetes.
Not diabetes, pre-diabetes.
I'm gonna say it not for me because I have never heard of it. No, yeah, I've heard nobody talk about that.
Okay.
Never.
They talk about pre-diabetes, even at your.
And that's kind of disturbing that nobody even mentioned that to us. That we don't learn that. I don't understand that.
They're not knowledgeable of pre-diabetes. They just know they got the sugar diabetes when it's full blown.
She said borderline terminology. Borderline, is that pre-diabetes or because we hear borderline and you assume, well, I'm borderline, but I'm not. I'm okay because I'm not a diabetic, but I'm, so it's the terminology and the strength of what are you using because That's something I've heard in the. Oh, I'm borderline. So are you pre-diabetic or what? You know,
Borderline.
Same meaning.
Well, borderline.
Borderline, okay. Angie, you have pre-diabetes?
Borderline, that's it. That's what it is.
You never heard the term?
I've heard the term,
But don't know, but not really familiar with it.
you're close
Frederick,
to
familiar
it.
with pre-diabetes?
I heard, but I ain't familiar.
Okay.
Like I go to family practice. I've been going there for 20-something years, and nobody's ever mentioned pre-diabetes to me.
No one's ever mentioned.
No.
That's cool.
Yeah.
And I'm just curious. To me, that should be one of the places.
I feel like I'm kind of robbed of the information that I didn't get of how important this is.
That's good.
And that's just the way I feel.
Pre-diabetic is reversible, but a lot of times, if you don't know the symptoms or have any knowledge or information about it, by the time you realize you have belonged to the full diabetic. So if you know, you would do better, eat better.
I think it's a caution sign. I think you need to be more aware of your body when something is going wrong, that you need to go get checked out. Because if you prolong and try to diagnose yourself, as black folks, that's what we do. I think just a good hour or two, go to the doctor. It can be taken care of, tracked at an early stage.
But I'm like them when I go to the doctor. That's one of the things that they check for, especially among, if you're black, overweight women, they're going to check for that. So I'm just glad that they are at least doing that part, because other than that, we probably wouldn't never know how to check it for ourselves or whatever. Or we find ourselves where we're in it so far that it can't be reversed or dealt with by doing something different with your diet or having to go on medication and get the shot, stick yourself and all that.
In our culture, I think that we've been conditioned to believe that if you cut, you bleed, okay, I need to go to the doctor. But if there's something going on that I really don't feel, or to check to see if something going on, we don't do it. I mean, we have to really be to the point of we feel the physical pain, we see the physical pain, then we go into the doctor. But just to anything that's preventive, that's just one of those things. We're just not conditioned to do it.
We don't seek medical attention as often as we should, so then the pre turns into the types 2. We're not going to the doctor because we're younger, we're healthy, but then when we do stop to the doctor, it's, oh, you're in trouble.
So as one of the things you could see with the discussion there was that, there was a lot of differences in terms of what information people were getting from their healthcare providers. And so that was something that stood out. So with the 6 groups that we did, 4 of the groups were with participants who had never been involved in a diabetes prevention program. And then 2 groups were with participants that had either been in a program and had some type of been referred somewhere to deal with a diabetes, So with this concept, what we did in the 4 groups that had not been involved in programs, what we wanted to do was share them a description of what a diabetes prevention program consisted of, to see if they felt like it was something that would be of value, something that was important, and something that they would be interested in. So this is a portion of the description, as you can see here in the italicized text. That's a portion of the description we gave. We also talked about, how long that they had to participate for like the first 6 months, and then going into the year, and how the groups were set up. But, we just wanted to share that with you. But based on the description, participants thought there was actually an extremely valuable resource. And what was interesting, where they said that, even if they didn't have a diabetes diagnosis, that they thought that, the actual program would be a benefit to them, because it would just be something that would help them change their lifestyle. So when we went through the different types of features, participants really zeroed in on, how to prepare healthier foods, like nutrition classes. They thought that was the most important issue and feature that a diabetes prevention program could provide, because they said, they knew theoretically what to do from a activity standpoint. It was just a matter of being motivated to do it. But, we heard so many people talk about living in Louisiana and the culture of Louisiana foods, and how that that was almost, you're almost predisposed to diabetes because, you're eating these cultural foods in Louisiana. So that was something that they felt was important to figure out how they could make, healthier versions of the foods that they love. So they thought that was a great feature. They also thought the aspect of having a support system with their peers who could hold them accountable was something that was also very important because, as many of us have known, to try to make lifestyle changes, it can be difficult when you're trying to do it, on your own and don't have the support of others. Pam, did you have anything else to add to this?
Yes. One of the things that I wanted to just kind of piggyback on what William was saying about people seeing it as a valuable resource. There were a number of people who, even though they thought perhaps I don't need this information myself, forgive the people in the background. I don't know who they are. Some people outside my house here. But at any rate, even if they didn't need the information for themselves, from seeing these video clips, you could see that so many people had someone in their immediate family or a friend who had been impacted. So there's also a value of people learning the information or having the information so that they can share it with others in their homes, in their families, and in their communities. So, for the most part, programs are set up to work with people who are at the pre-diabetic stage, but it's also an interesting thing to kind of think about of how can you get the opinion leaders or the chief medical officers in families also to attend these programs so that they have the information when someone they know needs it.
Thank you, Pam. That is very important because as we talked about earlier, a lot of people were responsible for taking care of family members that had diabetes. So having that knowledge of how to help them, very important. Other criteria that people mentioned that would be important for them to know when it came to deciding whether to join a program were the cost. Is it covered by insurance? Accessibility. A lot said that it needed to be in their community. It needed to be easily accessible to them. Convenient times. They talked about something that they could attend even if they were working. And then having a social aspect to it, keeping it interesting, making it fun and enjoyable, and something they look forward to coming to every week. So let's play another video clip here as they talk a little bit about what they need when it comes to diabetes prevention. Yep.
I think we have a lot of information in Lafayette on health, but not enough information on how to incorporate it into your life. I think, they give you information, but show me or give me a demonstration how I can prepare foods healthier. We know fruits and vegetables is healthy. We know, but we might not prepare it like how we eat cabbage and smothered, and all that.
Mine would be meal prep, because I can exercise. I know what to do to get my heart. It's just doing it, but mine is I want to eat something that tastes good, and it doesn't have to be fried, but I would have to know what portions and what particularly to eat.
I'm pretty much, that's very important, and that's just something, because we're just used to cooking what we cook, and that's been our norm, so it's kind of changing and going around that corner to do something different that's healthier for you.
A dietitian.
So a dietitian
to keep us on track.
Right.
Yeah. A menu. Yeah.
I don't know what to do. And a chef.
Yeah, that's a good one.
Somebody to come home with me, double check that ice box, get a calendar in front of you, and make me stick to that calendar.
Okay, so now I want to shift to the discussion we had with those participants in the two groups that said they had been involved in some type of diabetes prevention program or had been referred to some type of service. Now, I must say that from a recruitment standpoint, it was very difficult for us to actually find members of the community that had been in these programs. It was, you know, it was a tough recruit from that perspective. And so I think even from that, it shows that we need to really raise awareness of these programs in the community so that people know that they're involved or that they're available for them. So there were 4 participants who had been, you know, diagnosed with prediabetes or diabetes and then referred to some type of program. Only one of them was actually referred to a full-scale diabetes prevention program, and that was by their medical provider, and it was at the VA Medical Center in Shreveport. And so the other 2 patients were referred to kind of just a general one-on-one meeting with a nutritionist, where they said that they were given some, you know, information about how to change their eating habits and given some materials, but it was kind of a one-off situation. It wasn't an ongoing situation. And then the other person said that they had not been referred to anything, but actually found out about a prevention program at a community event where the program had a table, and that's how they ended up finding a DSME program. Now, the 2 participants who had taken part in a DSME program were asked to rate their experience on a scale of 1 to 10, with 10 being the highest. And they both gave it a rating of 8. So they felt that it was valuable. And both stated that the support system and the accountability generated in the group setting was what they felt was arguably the most important aspect. So the support system and the accountability. Participants also mentioned that the programs allowed family members to be involved, which they thought was important because it enabled their family members to see what needed to be done in terms of the lifestyle changes and things of that nature. The lady who was in a program is called CYL2 Healthy Lifestyle Wellness Program in Lafayette. So she had actually found out about this program at a community event. She wasn't referred by her medical provider, but she had participated in the program, felt it was good. But one of the things that she said caused some people to basically drop out of the program was a lack of childcare. I think she said they started off with roughly 10 to 12 that were in her group, but by the time she came to the focus group, she said there were 4 that were in their group consistently. And she said most of the women that had dropped out because of lack of childcare, and they just couldn't, you know, they weren't able to bring their children there and do that while participating in the program. They also said that they would have liked to have seen some, you know, cooking demonstrations and things of that nature. But from all this, it just really emphasized to us that these programs really need to be promoted better within the community, because a lot of people have not seen this information promoted. They've seen diabetes promoted in terms of medicine and things of that nature, but never for prevention programs. So Pam, did you have anything to add to this?
Good on this one, thank you.
Okay. So let's talk a little bit about raising awareness for diabetes prevention programs. So participants did talk about a high level of trust in faith-based communities and community organizations. So outreach activities for increasing awareness included things like distributing and displaying print materials and distributing information through public libraries. They talked about barbershops, hair salons, grocery stores, and medical providers, quite frankly. They talked a lot about the African American church and the respect and credibility that they had for disseminating health and wellness information. But there was also a sense among participants that churches needed to be better educated about these issues. They said, you know, pastors and church leaders needed to be educated about diabetes awareness and prevention, and they also needed to understand how they can implement health and wellness programming into their ministries, because a lot of these churches do have nurses and people that deal with health and wellness, but they said that it was kind of, they would do an event, but it wasn't something that was consistently brought up throughout the year. But they said that was an opportunity that could really be taken advantage of. We also asked if there were a few individuals in each community who had credibility as message senders. In Shreveport, they talked about Dr. Marius McFarland And in Lafayette, City Council member Kenneth Boudreau was mentioned as somebody that had a lot of respect within the community. Pam, did you have anything here?
Yeah, I just wanted to kind of talk about the Black church piece. Generationally speaking, it's been a place of credibility in the community. And I just kind of want to throw a caveat in there that, believe it or not, there are Black people who don't go to church every week or don't go regularly. And so I think we have to think a little bit outside the box on how do we reach those folks. What are the credible message senders, organizations, that are in the community where we can reach people who are not tied to a faith-based institution, and that may require a little more boots on the ground, hitting the places that they shop and hang out more so than where they are on Sundays. So just wanted to have that in there as part of the discussion.
And that is a great point, Pam, to add. And personally, we really reinforce the steps of community outreach when it comes to reaching African Americans in the community. I mean, it's something that we've done specifically for the Department of Health. We've also done it for the Louisiana Public Health Institute, where we've actually gone out, taken information to barbershops, taken information to childcare programs so that they can disseminate that information throughout. And it is a very effective way to build a credible distribution network in the community that people respect and access on a daily basis, and are places where they're getting your information, right, sent to them, given to them through their peers or through people in their community. So it adds to the level of credibility to that. So let's take another clip here, people talking about outreach.
Keep it in the forefront of people's mind and stuff too, because when you can't tell somebody something one time thinking that they're going to do it and stuff, it has to be constant. So if we bring the information to them and give it to them, it may become more important for them to seek medical attention.
Now we need to go to community centers that's in the impoverished areas and conduct the same health screenings there. In the projects, in those places. Go there and conduct the health screenings to get those people to come in.
I say we do need to have more health fairs in the communities, like them churches on the weekends. Maybe y'all need to go to them to make it easy for them to get to these checkups.
Some more pre-screening opportunities out in our neighborhoods where they would do things like that, because they'll go get free phone, but they need to go, for something to go get pre-screened so they will actually be aware. Where they actually set up camp and actually test people and let them know, if they're on that verge.
There could be a booth at every festival talking about diabetes, or talking about high blood pressure, or talking about things that affect the community and stuff. It's just like constantly being there so that they'll see it.
The churches also have health expos from time to time.
I think one of the biggest things is talk about it in the church, because everybody go to church, educated in the church, get them in the church.
The faith-based organization is not doing as much as it could be when it comes to health. Knowing that it affects us the most in this community, the Black churches are not doing their part when it comes to getting that message out about health. They're not doing their part.
Those topics are being discussed, but they're not being discussed frequently.
At my church, I know we do be healthy or something like that. And we do it maybe 2 to 3 times a year. And so that day, we have the nutritionists come out and we go from place to place. And so it's talked about and it's done. But so once that Saturday is over with, it's over with. It's over with. It's not brought back up on a weekly basis.
If the pastor doesn't know, then how can he give it to the
You have to bring people in with the knowledge. It's like this. Everyone almost now have a nurse in their church. Almost everyone. So get the nurse to make the connections to bring the health fair to the church.
And I think that would be awesome for churches to educate one another. and educate their members.
All right, so now let's shift the conversation to recommendations. And we've kind of broken these out in a few different ways. We have some programmatic or internal recommendations for you, as well as some message development recommendations, and then some promotional tactics as well. So first, it was pretty apparent, at least to me, that medical providers or primary physicians were not making people who are diagnosed with prediabetes or type 2 diabetes aware of diabetes prevention programs that were available to them in the community. I mean, very few participants, as you saw, were aware of the existence of the programs. Yet when the information was shared with them, there was a lot of interest in learning more about them or participating in them. So there's an interest. It just doesn't seem like the awareness is there. So there needs to be a concerted effort to ensure that all sectors of the provider community are aware of diabetes prevention programs and are encouraged to refer patients to these programs, even if they're not, located or run by the facilities that medical provider might be affiliated with. We also saw that there should be a focus on partnering with organizations and influencers who have the strongest grassroots relationships. So this takes some, time to understand who those individuals are, who those organizations are. But when you get that information, it's fostering the relationships that allow you to, work with them and collaborate with them to help get your message out. And as I said before, this strategy really will enhance the community reputation for your program at the grassroots level. Another thing that we saw was the value of the prediabetes risk test. And I have a clip after this to show you, but that's an opportunity, if that risk test is distributed and shared with people, it's an opportunity to be a conversation starter with patients. It's a way to get that discussion going, help them see whether they're at risk, whether they're not at risk, and then kind of bring that conversation up when they may not be interested in talking about it or willing to talk about it or even know to talk about it. So the diabetes risk test should be used more frequently. And then to address the issues of childcare, we thought that, one thing that could be done is potentially offering a stipend to cover babysitting or explore partnerships with childcare facilities that are in the vicinity of your program to see if you can arrange some type of short-term agreement or on-site support so that families that participate in your program do have childcare options, and that's not a reason for them to opt out of your program. Pam, did you want to add something here?
Good here. Thank you.
Okay, so let's play people talking about the diabetes risk test.
I mean, just from this little survey, these little questions, simple, to the point, makes you aware of where you are.
I don't want to be this 5. So for me not to be the 5, then I need to do something that I can do something about, which is my weight. Okay, and the blood pressure. So I'm thinking if I can drop some weight, get back into the other category here, then I won't be one of these people that will be in that category. So see, actually, just sitting up here, having taken this a few moments ago, that's sitting up here on my mind. I'm thinking, okay, I need to get back in the chart 1, so I won't be on the overside of the 5.
For me, it's pretty accurate. Pretty accurate, and I will ask my doctor more about pre-diabetes and diabetes because I'm hooked on sweets, and that's not a good thing for me.
It's telling me I'm in trouble. I don't know about y'all, but I go to mine.
If you will put this wherever you can, this should be the first thing they ask you when you come to the doctor's office, after what are you coming in there for. These points right here, I mean, these little bullets, it'll get you thinking.
I think some doctors ought to have surveys like this here with your incoming paperwork. So when you do your paperwork coming in, they'll take this little quick survey and they look at it like, oh, did you know that's time to open have that conversation.
What are some ways to get like this type of screening in front of people without expecting them to actually go to a medical provider?
People on Facebook.
I think it would be that good to give in the mail.
Okay, so hopefully that shines some light on the importance of the prediabetes risk test and how it's a great tool for kind of sparking the discussion or sparking the thought process community members. So let's move to message development. One thing that was apparent when we spoke to people early on and asked, what's important to you in your life, kind of in our introductory segment of the focus groups, a lot of people talked about quality of life, and whether that was, and it wasn't really, they weren't talking about it from a financial standpoint. Typically, it was quality of life in terms of being able to move around, being able to get where they wanted to get. Some just said, wanting to be able to get up the steps on my own, those types of things. So we think there's an opportunity here that when you're presenting your message around diabetes and diabetes prevention, is to focus on quality of life, and not just the quality of life of yourself, of the individual, but also the quality of life of their family members and things like, and those that take care of them and that are a part of their lives. And one of the things that we talked about also was foods, and it's an opportunity to give examples of what eating certain foods can do to your health, as well as the severity of the disease and what it can do to your body. So tying the food consumption to the impact that it has on your life, and helping people understand that as they move through life, you have to start to make lifestyle changes. I mean, typically, as we all get older, from a physical standpoint, we know that there are things that we can't do that we used to do when we were younger. Our bodies just aren't reacting the same. But I think sometimes when it comes from a nutritional standpoint, we also need to understand that there need to be shifts as we get older in terms of the things that we eat and the way that we go about preparing foods and things like that. And so it's helping people understand that, but then also giving them some micro steps about how to do that. Ken, do you want to add to this part around message development?
Yeah, I just wanted to say about quality of life too. I was just thinking about what William said about these were not pie in the sky quality of life issues, but just being able to do the daily activities of life. But I think particularly in what's been going on in America over the last couple of months, I think too another way to frame quality of life is the strengthening the ability to be resilient and to deal with the challenges that just come with living in the times we live in is also a selling point for that discussion.
Mm-hmm. Thank you. Another key point is that people need to understand, and we talked about this earlier about the knowledge of prediabetes, but people need to understand that prediabetes is not sentencing you to diabetes. It is reversible with the lifestyle changes. And I think that's one thing that really has to be shared, that you can prevent yourself from getting full-blown diabetes, even if you've been diagnosed with prediabetes, if you really take these lifestyle changes seriously. Also, when talking to patients, it's important to, again, refer to diabetes in the ways that they talked about them in their vernacular. So we talked about how they really describe it as sugar diabetes or having the sugar. And those are ways to at least bridge the conversation, get on the same page, increase your credibility and familiarity, and then you can get more into the scientific or the medical diagnosis. But it's just a way to help bridge that gap so that people fully understand what you're talking about, and it's being brought to them in the way that they describe it within the community. Also, promoting your program as a source of information and peer support is important. Those are two things that we saw were very important, that people saw as an interest, and let them know that these programs can help you make the lifestyle changes that can inevitably head off the negative health consequences that many of the individuals and participants talked about, seeing their family members go through or they had gone through themselves. And then create messages that appeal to women as the family's chief medical director. And Pam, do you want to elaborate a little on that?
Sure. Well, as in many families, it is the woman in the family who's doing the food shopping, who is doing the cooking, who's setting the schedule. And so, and also, unfortunately, doing the caretaking when someone gets sick. And so not really from the perspective of let's just add one other thing on to their plate to do, but just to recognize their role as a person who can lead a family in a good direction or a bad direction, and also be a good role model for themselves and others in their family about we can do this differently and change the statistics where we are overrepresented with these negative health outcomes.
Thank you, Ken. And so finally, we wanted to talk a little bit about promotional tactics. And, we wanted to give you a breadth of tactics that could be used. Some may be within a budget, some may be outside of your budget. We wanted to just kind of give you the full gamut of what we thought are some promotional tactics that can be used. The video testimonials, okay? A few participants suggested that, capturing reality-based testimonials from those who had successfully completed the program would be a valuable tool for promoting it. It allows prospective participants a glimpse of what to expect, and it provides validation that the program can work for individuals that look like them. And creating these peer-driven videos, also provides a wealth of content for you if you do have social media platforms or a website that you can post. And it just, it gives the people an opportunity to hear from somebody that's been through it and that they can relate to. Also, the pre-diabetes risk test. We've talked about it quite a bit, but again, it's a valuable tool. And we think that you could even enhance it by adding a short message to it regarding pre-diabetes can be reversed and a clear call to action. So one of the things that we thought about was from a scoring perspective, say somebody scored 3 or below, there could be something that says, continue what you're doing. If they score 4, then it's like continue what you're doing, but watch your weight. And then if they score 5 or higher, it's like you're at risk of having pre-diabetes or type 2 diabetes, and then some information about your program. Contact our program about that. So, it's giving them something that they can actually do after they've gone through the test. Now their interest is sparked. They're aware of what's going on. Give them a call to action right then when it's on their mind. Another thing, we heard participants talking about bringing the information to the community. So we thought that you could do one-on-one meetings or virtual meetings about your diabetes prevention program with representatives from faith-based institutions, various community-based organizations, and community influencers. Make sure that they're aware of your programs and your offerings so that when they're in their daily lives, when they're doing the work that they do, they can seamlessly refer people to your program without much effort on their part. It's just making them aware and building that relationship. We talked about canvassing communities, distributing materials to faith-based institutions, particularly, these are places that the pre-diabetes risk tests could be done. I envision that, that could be done at a church service where everybody has it and then they take it, you do it as a group and then everybody has that information and there can be a discussion about it, at the service, but people are made aware of it. And then the other thing is make a concerted effort to reach African-American men with your diabetes prevention messages in non-medical settings. I mean, one of the things that we saw from the focus groups, we didn't have, many men in the groups to begin with, but a lot of the women were fairly regularly seeing doctors, every 6 months for checkups. So they were interacting with providers and medical providers more frequently than men were. We found that men typically were only going to see medical providers or going to the emergency room when they absolutely had to. They really weren't going in for prevention. So how do you get these messages to them in non-medical settings? So that's why we talk about, barbershops, job placement programs, ex-offender programs, other places where men gravitate, libraries, places like that where you can share this message with them and make them aware. Pam, did you have anything to add here?
Yeah, just real quick. So yeah, we recognize that everyone cannot do everything. Some people are working with no budget. Some people are working with a little bit of budget, but we hope overall, even if you have no promotional budget, this has given you some ideas about if you're having one-on-one conversation, you're meeting people to talk about your program, you have some idea of the context of their lives that will help enrich the conversation and help you engage with them more effectively.
Thank you, Pam. So that's how the final slide for us. I really just want to say before we open or try to get to the questions, is just that there's a great opportunity, here for you all to raise awareness for these programs, get people involved in these programs, and the need is there, the desire is there, the interest is there. I think it really comes down to making participants aware, being able to communicate your message, and being able to make your programs as accessible and convenient to them as possible, so that they're able to take advantage of the valuable information that you're sharing. Because as we've seen from the focus groups, I'm sure all of you know that it's absolutely needed a resource in the Black community, not only in Louisiana, but across the country. So we do want to, I'll turn it over to Marcy if she wants to add, because this is our final questions, and I can try to see if there were any questions that were submitted. Marcy, did you want to jump in?
I do. Thank you so much, William and Pamela. This is such valuable information you shared with us. It was really great. But I do want to take a minute, and I'm not sure, William, if there's a slide past this one.
Yes, there is.
Okay.
Jump to it. Sorry. There you go.
Okay. Thank you. I just want to share some of the program availability within the state and details on an upcoming training. So Louisiana currently has 14 national diabetes prevention programs and nearly 70 diabetes self-management education and support programs, or the DSMES programs. And to find these programs, you can visit Well Ahead's Community Resource Guide, which can be found at wellaheadla.com/CRG.